Welcome, everyone. We're going to go ahead and get started for the sake of being respectful for our guest speaker's time. My name is Jess Pelletier. I'm the medical director for Techies Without Borders. And we're very excited today to have Dr. Emmanuel Idowu, who is our Nigeria liaison for Techies Without Borders, coming as our guest speaker. Emmanuel is a professor of emergency medicine at the University of Ibadan, where he also serves as a consultant emergency medicine physician, a faculty member, and a postgraduate medical trainer and lecturer. His expertise is in the area of stroke in emergency care. And without further ado, I will let Emmanuel take over. Thank you so much for being here. And as a reminder to those of you who have not attended before, this is meant to be an interactive event. So please ask questions in the chat, chime in with anything that you are thinking about as the session goes on. I'm sure Emmanuel will open the floor and ask for responses from the audience regarding what you do at your institution. So please do chime in. And without further ado, go ahead, Emmanuel.
Highly esteemed participants, you are welcome. Thank you for joining us today on the July edition of our Journal Club, powered by Techies Without Borders. I'm quite excited with you all on board. I've been tasked with the responsibility of taking you on a 60-minute presentation. With me is the co-pilot, Jessica Petelian, an associate professor of emergency medicine. Congratulations once again on your new role and your appointment as Associate Residency Program Director at the University of Missouri, Columbia, in the United States of America. Thank you for that soothing presentation. I quite appreciate. Thank you for being a blessing. Next slide. I'll be taking you on acute stroke care, the ABCs and XYZs. Displayed before you is the agenda to guide this presentation. Let's delve into the presentation proper. The World Health Organization defines stroke as a rapidly developing clinical signs of a focal or global disturbance of cerebral function, lasting 24 hours or longer, or leading to death with no apparent cause other than a vascular origin. Most authorities and school of thoughts still play with that definition. However, there is a global shift. But epidemiologically, let me sound this to us that stroke is still the number one leading cause of death globally. It is the second cause of disability globally. And Sacco and colleagues red flagged to us in the last decade of a widening gap between settings, for example, like the United States of America, and low and middle income countries like Nigeria, sounding us an alarm of the widening gap in the stroke burden that is being contributed by high income countries and low and middle income countries. And the figure quoted was quite alarming, as at that time they did their systematic analysis and meta-analysis of the global burden of disease study in 2021. Pointing us in the direction that effort has to be put in place in comprehensive acute stroke management. Consensus is shifting in the perspective in regard to the duration, the histologic dimension to stroke, and the clinical perspective. You don't have it until it is 24 hours or even below before you make a decision on stroke, because stroke is usually in evolution. Next slide. Next slide. Yeah, That is a schema. That is a schema showing you the widening gap as noted by Sacco and colleagues in their systematic review and meta-analysis. The yellow line is showing the low and middle income countries, while the green line is showing the high income countries. You can see that high income countries are doing phenomenally well as projected by them between 2020 and 2050. In fact, they quoted a 46 to 83% increase from the baseline that was quoted in 2019 regarding all age-related global stroke burden that is contributed by low and middle income countries. Matter of factly, they also talked about disability adjusted life years, projecting that 30 to 74% increase is going to come on board between 2020 and 2050. And prophetically, as they said, the realities are staring us in the face today. Idowu and colleagues are corroborating the same figures that are quoted in that there is an epidemic in the Ibadan environment and there is a pandemic globally as we talk at the moment. The more reason why this presentation is of essence to bridge the gap between high resource centers and low resource communities. Next slide. That is a picture that is showing us the computerized tomography non-contrast of an ischemic stroke and an hemorrhagic stroke. You can see a huge right-sided hypodensity, especially in the frontoparietal region, causing a midline shift to the left with of the adjoining ventricular system. That is big stroke there. And you can see the hemorrhagic variant. You can see an hyperdense lesion, rightly situated on the right hemisphere, also causing a midline shift to the contralateral side with the effacement of the adjoining ventricular system. Aside that, we have two broad categories of stroke, ischemic and hemorrhagic. I want to put it to us that ischemic can transform to hemorrhagic, which is what we call hemorrhagic or chronic sarcoid hemorrhage, artery, some of the other variants for stroke. Next slide. Next slide. Yeah, that is corroborating the shift, the global shift in the definition of stroke. The American Academy of Stroke is giving us a new dimension to read. Do well to look at that literature as displayed. Transient ischemic attack is a clinical syndrome that is characterized by acute loss of a focal cerebral or monocular function lasting less than 24 hours, and which is thought to be due to inadequate cerebral or ocular blood flow as a result of low blood flow, arterial thrombosis, or embolism related to diseases of the heart, arteries, or blood. And the old definition is showing a clinical perspective, but the new definition is showing us the histologic dimension to read, in that transient episode of neurologic function caused by focal brain, spinal cord, without acute infarction. Once you pick an ischemia, that is already justifying. Thank you. Move to the next slide. Next slide. Yeah, the acute stroke care is fractioned according to the triangular model into level 1, level 2, and level 3 of care. Level 1 care is provided at the level of maybe a clinic, a primary health center, or district hospital, as it may apply, where you do not have physicians as luxury. Most often, they are non-physicians that provide essential care, minimal access care at that particular level. Level 2 is the care that is provided maybe at the state general hospital, where specialist services is not available 24 hours. However, you can have luxury of some neuroimaging, like the computerized tomography. Level 3 can provide 24-hour specialized care for a patient who have developed stroke. They have multimodal imagings, acute stroke care team on standby to provide care as necessary. Next slide. Next slide. Yeah, we are trying to make this presentation as interactive as possible. The first case is that of Mr. XY, who is presenting with symptomatology in keeping with stroke. We want to know what is going to be your guiding principle in terms of management of such a patient. Can we get a volunteer from the house to give us a spot-on care approach to stroke based on what you do in your center, imagining that you have a level 1 facility at your disposal? Jessica Petelia will moderate this part. Over to you, Jessica Petelia. Over to you, Jessica Petelia. Please moderate the cases presentation.
Yeah, absolutely. Thank you, Emmanuel. I have a lot of tabs open trying to moderate the chat and stuff. Sorry for the delay there. So what would be your first plan of management at your particular institution, team? Please feel free to chime in the chat. Sarah says, what is projected in case 2? So it's a patient with sudden onset slurring of speech and left-sided facial droop, and they have left hemiplegia. Symptoms started 3 hours ago, and his wife noticed these symptoms and called for an ambulance, which arrived within 15 minutes, meaning it's been less than 4.5 hours since this patient's onset of symptoms. So what do you think you would want to do with this patient? Let's say that you're working in a center that can provide level 2 or level 3 stroke care. Yes, thank you for pointing out. We accidentally skipped case 1. We'll go back. Thank you for pointing that out. Regina says imaging within 4.5 hours of symptoms to rule out a hemorrhagic event. Correct. Let's say, Regina, that the CT head is negative for an acute intracranial hemorrhage. What would be your next plan? Yeah, perfect. Going through contraindications to thrombolysis. Thank you so much for your participation. So guidelines recommend that all we need is a CT head. If you don't have a CT angiogram or perfusion study available to you, that's okay. You work with what you have. And so we need to exclude an intracranial hemorrhage and then find out if this patient has contraindications to thrombolysis, since we're within the 3 to 4.5 hour window. And thank you, Regina. Get the ABCs of resus going. Exactly. So if the patient has airway breathing or circulatory compromise, that needs to take priority. I'm going to go back to case 1, which I skipped by accident. I do apologize. I'll read this one out loud as well. You have a 93-year-old with sudden onset inability to use his right, upper, and lower limbs, and rapidly progressive alteration in sensation. His symptoms started 9 hours ago. So what would you do with this patient? So we have 9 hours of stroke symptoms. Yep, exactly. Same step here, Regina, imaging to rule out a hemorrhagic event. Let's say that once again, there's no intracranial hemorrhage. Perfect. Thank you, Regina. So start antiplatelets, and we'll talk more about that later. Emmanuel's going to dive into it, but this patient is outside of the window to be a candidate for thrombolysis. Certainly, if you have options like endovascular available at your institution, those are things to consider for either case 1 or case 2, because those patients may be eligible up to 24 hours. But in most scenarios, just starting antiplatelets and other components of stroke care will be your priority. I'm going to turn it back over to Emmanuel to dive into the background on stroke. Emmanuel, you still with us?
Yeah, am I audible?
Yes, you're perfect. Thank you. I think you're muted again, Emmanuel. If you could please unmute yourself.
Am I audible?
Yes, now you are.
Yes, you are, sir.
Oh. All right, well, it looks like Emmanuel's muted again. I'm just going to talk through the epidemiology until he comes back on. Stroke is the leading cause of disability globally, second leading cause of death. And we talked about that a little bit earlier. This infographic just shows you how big a deal stroke is. And critically, 90% of all strokes are linked to 10 modifiable risk factors. So this is a very preventable thing. 1 in 4 people over age 25 will have a stroke in their lifetime. So this will affect many of us. Emmanuel, can you hear me again? Are you there?
Yes, I can hear you.
Oh, hi, Emmanuel Effa. I meant Emmanuel Idowu, our presenter. I don't know where he went. Welcome, Emmanuel Effa. Oh. Well, I'm going to keep talking until we get our presenter back. So in terms of pathophysiology, ischemic stroke typically involves large artery occlusive disease, but can also come from cardioembolism and small vessel disease. You end up getting inflammation and reactive edema in response to infarction. A penumbra refers to the compromised tissue that's affected by decreased blood flow in the setting of acute stroke. Emmanuel Idowu, can you hear me? Are you back with us?
Yes. This is Emmanuel Effa.
Hello,
Sorry.
Jess.
Emmanuel Effa, we're trying to get our presenter back. It's Dr. Idowu. My apologies. We've got 2 Emmanuels on here. Can you hear me, Emmanuel?
Okay, all right. Yeah, am I audible?
Yes, you're audible.
Am I audible?
Yes.
Okay, perfectly. So I wanted to provide some background regarding the epidemiology of stroke. I said 1 in 4 individuals over 25 years will have stroke in their lifetime. I pray that we are not part of those folks, but it is worthy of note that stroke does not respect your age, your status, your education, your race, your level of professionalism. In fact, physicians or surgeons could be victims. 90% of strokes are linked to 10 modifiable risk factors. 12.2 million new stroke cases are recorded per annum. 101 million people still live with stroke aftermaths. Then 143 million individuals have 80 years of life lost to stroke. Next slide. The common pathophysiology that is underpinning the etiology of stroke revolves around the concept of occlusion of either small vessels, large vessels, causing ischemia and infarction of brain tissue, active inflammation and reactive edema, or reactive gliosis as it may apply, with infarctive zones. of umbra, which is the core, which is usually non-salvageable, while the penumbra, which is the outer region overlying, is the salvageable region, depending on how acute our intervention is. Hemorrhagic stroke, that is for ischemic stroke. Hemorrhagic stroke, however, is underpinned by vascular rupture and bleeds or rebleeds post-recanalization from affected primary or collateral vessels. This includes hemorrhagic transformation of ischemic stroke, like I did say, ab initio. Associated risk factors and comorbidities exacerbate progression and evolution of stroke. Next slide. Next slide. Next slide. Am I audible? Next slide.
Yes, you are audible.
Next slide, please.
You want me to skip?
Yes, skip
Okay.
pathophysiology. I'm done.
Okay.
Yeah. So thank you for that. We move to the basic anatomy, talking about the ring of Willis that provides arterial distribution to the brain. You can see the ring that is made up of the anterior communicating artery, middle cerebral artery, posterior communicating artery, posterior cerebral artery, anterior communicating artery, posterior communicating artery. This is of importance.
Emmanuel, I think your internet may be unstable. If you are able to move to a different area, that would be great. We can't really hear you. Until we can get him back, guys, just a quick overview. This is the basic anatomy of the brain arterial blood supply. The circle of Willis is kind of the connection point between the anterior, middle, and posterior cerebral circulation. In terms of the clinical presentation for each type of stroke, anterior strokes tend to cause disinhibition. I think some of us are aware of the story of Phineas Gage, a gentleman who essentially had a pipe go through his head in his frontal lobe, and he was permanently disinhibited after surviving his accident. He swore a lot and was inappropriate. So disinhibition is kind of the classic. But other things that can happen would be weakness and sensory deficits that are typically worse in the legs compared to the arms, and difficulty with urinary continence. MCA, middle cerebral artery, is the most common type.
Am I still audible?
We can hear you now. Yes. We moved.
Am I still audible?
Yes, we can hear you now, Emmanuel.
Am I audible?
Yes.
Okay, perfect. So next slide.
Yep. We're
I
up
talked
to
about the middle cerebral stroke.
Yep.
That it supplies the upper extremity motor strip, hence the arm and facial weakness appears more than the limb. The presentations include contralateral hemiparesis, contralateral epiesthesia, ipsilateral hemianopia, and other gametes as listed. Next slide. Next slide.
I think
posterior cerebral stroke affects vision and thought more. The posterior circulation stroke affects the contralateral, the vision and thought more, presenting with contralateral homonymous hemianopia, cortical blindness, visual agnosia, and others as shown. Then most importantly, please look out for this diadokinesia. Next slide. Next slide. Yeah, let me go back to to give us the secret behind the high income climbs having a success in maintaining their stroke burden at a baseline. You can continue, please. Jessica Petelia. Jessica.
Yep, I think there's a delay in the slide.
Jessica, am I audible?
Yes, you're audible. I think that there is a
delay.
delay.
I said you can take over the ED evaluation and management part, telling us the secret behind some of the successes that you've recorded in maintaining a stable baseline as reported by SACO and colleagues, like I show in the picture between low and middle income countries and high income countries. Over to you. Okay. Take the ED evaluation and management part.
Apologies for the internet issues, guys, but just to recap, so this is one method of kind of recognizing a stroke. Just realize that a lot of the tools we have for stroke recognition are sort of biased toward anterior circulation strokes, meaning that they don't always pick up on posterior circulation strokes. The things we mentioned earlier, dysphonia, dysphagia, dysarthria, diplopia, dysdiadochokinesia, dysmetria, those things are not really accounted for as much as they should be in the NIH stroke schedule, in the NIH stroke scale. Okay, so just to emphasize, and I believe one of our attendees mentioned this earlier, I think Regina, it's incredibly important to realize that ABCDE takes priority, meaning airway, breathing, circulation, disability, exposure. So if a patient is not able to tolerate their secretions and is actively choking because they have severe dysphagia, that's going to take priority over bringing them to the CT scanner to look for an intracranial hemorrhage. So just remember that airway, breathing, circulation need to come before disability, which is where the neurologic part of things come into play. The NIH stroke scale, for those who are not aware, this is a US-based tool, and I know the Canadians have their own stroke scale as well. But we use this, at least in my setting, for allowing us to communicate with our neurology and neurosurgery colleagues. It allows for a common language to be spoken between everyone who is taking care of our stroke patients, and it allows us to assess for progression or changes in their physical exam. So check this out if you're unfamiliar with it. One critical important question that Regina brought up in the chat is figuring out the last known well time. So this allows us to determine whether someone may be a candidate for thrombolysis if we're dealing with an ischemic stroke. So we need to know if their symptoms started more than 4.5 hours ago, in which case they would probably only be a candidate for an antiplatelet agent, or potentially for an endovascular removal of a clot if that's something available in your setting and if it's a large vessel occlusion. Dr. Itawu will get into endovascular therapy a little bit more later. Remember that time is brain. So the longer we wait to give thrombolysis, the worse a patient's outcomes are going to be, meaning that we need to try and get this administered as soon as we realize that a patient is a candidate. And these are just those time cutoffs we mentioned a few moments ago. Critical imaging that we need to get in the emergency department. The most important is that CT head, as Regina mentioned earlier, to exclude an intracranial hemorrhage, since hemorrhagic strokes are going to be managed differently with reversal of anticoagulation, elevation of the head of the bed, sometimes surgical procedures, and often we have to treat those patients for elevated intracranial pressure or for issues that arise. For example, those patients can lose their airway quickly and decompensate quickly. And so we need to be ready to take the airway if needed. If you have CTA, that allows you to look for large vessel occlusions. A CT perfusion study, I'd love to hear in the chat if anyone has that available at their institution, but it's essentially a tool that allows you to see the balance between ischemic tissue and infarcted tissue so that you know whether there is any benefit to proceeding with a large vessel occlusion being removed. So I'm going to put this in the chat. Does anyone have access to CT perfusion? So essentially, they look at the balance of ischemic to infarcted tissue. And if the tissue is already infarcted, then there's not really a point in pursuing endovascular therapy. MRI, I would also like to hear in the chat who has that available to them. I will say I'm not usually getting that in the acute setting unless it's a child with suspected stroke. It's pretty hard to get a rapid MRI in my setting, and I'm sure in most of yours as well. But MRI is useful to help discern whether someone is having a TIA or a stroke, especially for those with mild symptoms. And it allows you to determine kind of the exact distribution of a stroke, especially for the posterior circulation strokes that are harder to visualize with a CT. So these are going to be the acute stroke care ABCs. This is the 8D model. So detection, meaning rapid recognition of stroke symptoms. If you have an EMS system, then sending them early to get the patient can obviously help accelerate their access to care. At the door, recognizing that the patient needs to go to a stroke center, right? So if they show up at the wrong place, hopefully doing whatever stabilizing care you have available to you. And if you don't have the right therapies for stroke, getting them to a higher level of care. Inside the ED, we need to be able to recognize signs and symptoms of stroke. And then we need to ensure that we have folks who have expertise in stroke evaluating the patient, whether that's neurology or an emergency physician. If you have access to fibrinolytics like alteplase or tenecteplase, then that would be typically the first line treatment. And if you have access to intra-arterial strategies, then those are helpful for large vessel occlusions. And getting these people to a stroke unit is critical because their outcomes are better if they're getting regular neurologic checks and being watched carefully and having their blood pressure carefully controlled. I'm going to turn it back over to Emmanuel for the 9-mobile innovative model. Emmanuel, are you able to hear me okay?
Yeah, thank you so much, Jessica, for that succinct presentation from you. Am I still audible? Yeah,
Yes.
Can you hear me?
Yes.
Am I audible?
Yes.
Hello? Am I audible? Okay, perfect. So I'll be taking the 9-mobile. Essentially, you should complete the following within 60 minutes of arrival of the patient to the ED. Efficient transport and triage system at ED must be in place. You must review the referral note from this point of the source of referral. Quick, fast history must be taken, and relevant clinical assessment tools put in place, like the NIHSS scale talked about by Jessica Petelier. Access the circulation of the patient, airway, and breathing. Yes, A, B, C, D, E, but most by experience, circulation can be given preference based on discretion. Prevent to minimize secondary brain injury from hypoxia, hypovolemia, etc., etc. Activate stroke team as soon as possible. Complete the initial evaluation and assessment, including appropriate neuroimaging modalities. Quick disposition to the stroke unit. HEM official follow-up progress. Then patient, provider, and public sensitization on prevention efforts must be institutionalized by the hospital. Next slide. Next slide. Yeah, these are the commonly used fibrinolytics, alteplase, tenecteplase, streptokinase. Alteplase is an FDA-approved medication. The dosing is 0.9 milligram per kg, as it may apply where you ration into 1 to 10 ratio. The first part, you give it within 1 minute, and the remaining part, you give it over the remaining period as per protocol. Then tenecteplase is a newly FDA-approved medication. You do the weight of the patient. If the patient is less than 60 kg, you give 15 milligram of the tenecteplase over 5 minutes, and you can always adjust the dose based on the response of the patient. Other local generics are also available based on local protocol. Next slide. You must weigh the risks and benefits. Is there a risk of intracerebral hemorrhage, systemic hemorrhage, angioedema, or previous history of allergy. You have to take those into perspective. Next slide. Yeah, these are the trending modalities to assist the brain optimization measures that are usually put in place in low resource communities where you do not have the luxury of these acute interventions like the endovascular thrombectomy. Some centers may not have luxury to some thrombolytics, either due to cost or accessibility. So this is showing us the catheter aspiration approach, and where the clot is aspirated using a specialized needle, then mechanical thrombectomy where you have to dislodge or break open the clot. These are new interventions that are in place now. However, they have their inherent issues as well. You may dislodge a clot and it embolizes into another vessel elsewhere. You may aspirate and it may injure vessels. So you need lots of expertise. You can put a telecall to someone like myself or Jessica Petilia or any other neurological emergency physician in the world through Techies Without Borders even link, and you'll be sure that you are going to get appropriate response as it may apply. Next slide. Yeah, these are some of the literatures that I reviewed. Advances in stroke quality and management by Don and colleague. Next slide. Yeah, it's the key components of improving stroke care were itemized, including documentation, weighing the patient before CT, considering stroke mimics. That's at individual patient level. Next slide. At institutional level, have your checklist, feedbacks, order sets, continue medical education, like Techies Without Borders is doing, to sensitize and give appropriate knowledge and skill to people across the globe. Next slide. Yeah, this is an emergency medicine faculty development effort at the University College Hospital. The gentleman in the green stripe in white on mask is the presenter. Next slide. The gentleman in white coat is the presenter. Next slide.
So at this point, just a question for, do people have stroke teams at their institutions? I know that University of Ibadan does have a group of people with great training in stroke, but I'm curious if all of you have access to a stroke team where you work.
Yeah, Jessica, I think we should throw this part open to everyone so that we can have contribution and an interactive session. Over to you, please moderate.
Yeah, absolutely. Does anyone have a stroke team at their hospital? And how does continuing education surrounding stroke work where you are employed? Please feel free to chime in the chat. This last article that Dr. Idawo just reviewed talked about the importance of having stroke teams, stroke protocols, having order sets. All of those things, along with continuing education in stroke, have been shown to make a better impact on patients. So I'm wondering what you have available where you work. Thank you, Sarah. No stroke unit teams or protocols and limited ICU space. Is there continuing education on stroke care where you guys work? Is there, supported by the institution, by your hospital? Does anyone receive continuing education on stroke care? Feel free to chime in out loud or in the chat. I'm going to move forward with the slides and have Emmanuel take over on the next article, and people can feel free to chime in the chat.
Yeah, thank you so much, Jessica. The other literature reviewed was management of acute ischemic stroke in the emergency department, optimizing the brain. Based on the response that we got from the previous interactive slot, you can see that most clients do not have this luxury. So the brain optimizing measures, I'm going to elaborate on this part, which is my position to bridge the gap between low resource settings and high resource climes. First and foremost, next slide. Ganti Latta did a brilliant work in doing a systematic retrospective scoping review of relevant up-to-date contemporary literatures. She pulled for analysis based on specific themes from available e-resources, provided evidence for the inferences drawn, and made submissions as appropriate, and itemized 12 steps that are critical for brain optimization measures when you do not have the luxury to either thrombolysis or thrombectomy. Step 1, ascertain the time of onset of symptoms. This is crucial for you to categorize patient as TPA candidate or not TPA candidate. TPA is tissue plasminogen activator. The duration is usually traced to the last well-known time. The second step, as itemized by Ganti Latta, was to obtain a non-contrast brain CT for you to be able to rule out intracerebral hemorrhage, which is an absolute contraindication for thrombolysis. Only non-contrast CT is needed for you to decide whether or not to administer TPA. Advanced imaging can be called for, but this must not delay the decision as to whether to administer TPA or not. The next is to obtain the NIHSS score. It is a 15-item, 42-point scale. The higher the number, the worse the neurologic deficit. Essentially, it's used for communication with neurologic colleagues and is for us to know the level of severity of the neurologic deficit. At this level, you can prepare your thrombolytic agent, but wait until you check for rapid blood glucose at blood side. For crying out loud, you may be having an hypoglycemic brain injury as a stroke mimic. Recurrent hypoglycemia has been shown to be detrimental to brain function. Hypoglycemia also has been associated with adverse prognosis following acute ischemic stroke. People have tried insulin to ensure tight control. When you have recurrent hypoglycemia or rebound hypoglycemia, D50 infusion is the way out for you to correct the hypoglycemia. Persistent hypoglycemia to the tune of greater than 200 milligrams per DL during the first 24 hours is an independent predictor for ischemic stroke expansion and poor neurological outcome. You quickly check for room air oxygen saturation. The goal of oxygen therapy is actually to prevent hypoxic brain injury, which can potentially worsen the ongoing ischemia. Supplemental oxygen should be provided to maintain oxygen saturation above 94%. Non-hypoxic patients, please do not need supplemental oxygen. Otherwise, you expose them to oxygen toxicity. However, there is a potential role for hyperbaric oxygen for a stroke secondary to air embolism. Please take note. Check the temperature of the patient quickly. Pyrexia is associated with worse clinical outcomes. Peak temperature in the first 24 hours, less than 37 degrees Celsius and greater than 39 degrees Celsius are often associated with increased risk of in-hospital death compared to motemic group. Fever etiology should be known. However, regardless of etiology, you must treat the fever. The best way to do this is usually with oral or rectal aspirin. Acetaminophen is another alternative that you can use. It also comes in oral and rectal forms. However, in our clients, for most of our hypovolemic patients, we try IV fibramol, which is an acetaminophen in IV form. Obtain a neurology consult if you have the luxury, maybe level 2 or level 3, while the decision of whether or not to give TPA is well within the domain of the emergency physician. In a busy emergency department, having an additional colleague to help with acute ischemic stroke can be extremely helpful because it's the commonest. Lack of a dedicated stroke team is significantly associated with longer door-to-needle times for stroke management. Consultation could occur in person or via telemedicine, depending on local hospital resources. Keep patients on NIPA ORIS. Post-stroke dysphagia is associated with risk of aspiration, pneumonitis, or pneumonia. A patient with decreased level of consciousness at greater risk of aspiration. It is important to note that a precise graft reflex may not indicate safety with swallowing. Antiplatelet agent trial is important. You can do a double antiplatelet therapy or single antiplatelet therapy. The American Heart Association recommends that you can do a double antiplatelet therapy, especially within 21-day presentation. The blood pressure management is essential. Yeah, do not crash the BP. A BP greater than less than 220, 120 is still good. If there is no hypertensive emergency, please take note, either an aortic dissection, hypertensive encephalopathy, or otherwise. You can bring the BP to less than 185/110 millimeter of mercury if it is a TPA candidate. BP medications that you can use include labetalol, nicardipine, clozapine, depending on what you have. But do not use hydralazine and nitroglycerin because of their vasodilatory properties. Be sure that you correct volemia, maybe from hypotension, either with a vasopressor or IV fluid. Obtain ancillary tests as it may apply. The essential action points that I will want to itemize upon include acute ischemic stroke is, like I've said, those are the essential 12 points that I've talked about. Let me cap it off with the decision for you not to anticoagulate. You may be worsening the ongoing bleed. Yes, as an emergency person, the good one knows when to thrombolize or to do endovascular intervention. The better one knows how to, but the best one knows when not to. You must know when not to, which is what is going to bring me to contraindications. Severe head trauma in the last 3 months, severe ischemic stroke in the last 3 months, coagulopathy, intracerebral hemorrhage, either in the concurrent or previously, intracerebral mass, space-occupying lesion, GI bleeds, GI malignancy in the last 21 days, low molecular weight heparin administration in the last 24 hours, some direct activated factor 10 inhibitors in the last 48 hours are some of the contraindications that you should look out for. And you must have the ability to be able to manage complications. Symptomatic intracranial hemorrhage that is presenting, you must DC the tissue plasminogen activator that you've administered. You must get a quick HCT. You must do give a cryoprecipitate. You must do antifibrinolytics, maybe aminocaproic acid, tranexamic acid. You must get supportive care from neurosurgery and hematology. Your management of allergy, if it presents maybe an angioedema, you must get methylprednisolone, diphenyladramine, H2 blocker like ranitidine, ecallantide or icabant are other drugs that you can give aside administration of fresh frozen plasma. Next slide. Next slide. Yeah, some of the literatures that were reviewed have their inherent limitations. The paper did not discuss many factors which influence ED presentation. The pre-hospital care and follow-up care were not fully captured. Next slide. Next slide. Other limitations shows the non-generability in low and middle income countries, but I've been able to bridge the gap through this presentation. Next slide. Just like how Jessica and I have been able to give perspective. So the next slides are just showing you some of the literatures that were reviewed. Pragmatic solutions to reduce global stroke burden, World Stroke Organization study, Lancet Neurology Commission. You can take time to look at that literature. Next slide. Let's go to the next literature.
Do you want me to skip this article, Emmanuel?
Yes, just skip all of those. People will go to study. Just show them the literatures that we reviewed because of the timing, so that they can have a look and go and read after this presentation, so that we quickly summarize and get feedbacks from people. It is the wise thing to do. It has been interactive. It has been lovely. It has been great. It has been awesome based on the feedbacks that we've had. and we've been able to bridge the gap between low resource settings and high income settings with this presentation. People are exposed to the modality for brain optimization if they do not have luxury for endovascular therapy and thrombolysis as it may apply based on inherent constraints in their climbs, but they can put a telecall through to us. I submit by saying that time is critical. Early recognition, EMS response, and treatment are essential for better stroke outcomes. And the onus of responsibility through our web communication, through our synergy, we can change the narrative, especially in the low and middle income countries. And Techies Without Borders is doing this already. Holistic care matters. Treat the whole patient. Don't just focus on the stroke. Don't be myopic. Address comorbidities and prevent complications. Accurate diagnosis is important. If you are not sure, please put a call through to a colleague, seek a second opinion. Adapt and innovate. That you are working in a low resource setting must not equalize a low quality care. Use the local protocols and be creative in your interventions. Collaborate globally, like we are doing through the Techies Without Borders network. Jessica Petelia, like myself, are both American Academy of Emergency Physician Fellows, and we are all doing best in our power to make sure that this narrative is changing for us to have a better stroke outcome as a result of this presentation. We welcome inputs from colleagues and respected participants. I appreciate you all for listening. Thank you for this time out. Lovely. These are some of my selected references. Over, Jessica Petelia.
Thank you so much, Emmanuel. We really appreciate you sharing your expertise. And there's a lot of great content in this slide deck. And so I will be sharing the content, the slides, and a summary as well as a video recording. I'm putting a link in the chat for the post participation feedback survey. If you could please fill it out. Someone asked for the slides before the wrap up, so I'll go back, Regina. Is this the slide you were asking for?
No, please, the one before it, just the one before this one.
Oh, this one?
Platelets. Yeah, okay, thank you.
Yeah, absolutely. And I'm going to share the slides as well as a summary of the session and the video on WhatsApp. Again, if you could please fill out the survey, we would be incredibly appreciative. And thank you everyone for understanding the internet issues. Sometimes that can be a challenge. We're so thankful for Dr. Idawu, who came and shared his expertise today. If anyone has questions, I'll stay on for the next couple of minutes. You can feel free to chime in the chat, or you can always send me an email or a text message later. I'm putting my email here in the chat and my WhatsApp number. And again, thank you so much.
Yeah, thank you so much, Jessica Petelia. Thank you, participants. We are open to your questions, any area of clarifications or gray areas. Your concerns will be appropriately addressed. She will share my email, my contact with you for you to reach me in case you want to put any telecall across regarding acute stroke care. We are open to provide the solid base for you to roll. You are not alone. You have us. Thank you. Over to you, Jessica. You can wrap up.
I'm sharing Dr. Idawu's email address in the chat as well. Oh, Rebecca asked a great question here. So in regards to starting oral antihypertensive drugs, good question. So in the acute setting, after you've given thrombolysis, and if you're trying to keep the blood pressure below 185/105, then you should be using IV agents. But if we're talking about the patient who's not a candidate for thrombolytics and they've got sort of high blood pressures that are creeping up above 220/120, I think it's fine to give a dose of an IV medication to lower their blood pressure and then start oral medications after that. If we're just talking about in the hospital after acute stroke, I'd prefer that for ongoing basis, patients are getting oral antihypertensive agents since they don't cause as drastic of fluctuations in the blood pressure. So to summarize, if you're not getting
Yes, let me add on to your submission regarding to that question.
Absolutely.
Yeah. So thank you so much for that question. Post-stroke dysphagia is something that you should look out for. You must do a dysphagia screen for the patient and get the patient cleared. If you have any doubt about the clearance, please do not use oral medications. Revert to IV and titrate to dose. Thank you.
Yeah, that's a great point, Emmanuel. Thank you. For ongoing management in the hospital, oral antihypertensives are definitely a great choice. But in the acute setting, if someone's blood pressure is getting to above 220 over 120, you really should lower it with an IV medication.
Yeah, Jess, did you get my response on post-stroke dysphagia?
If you want to repeat it, I think that will be fine, Emmanuel. Sometimes the internet.
Yes, I said that the participant asking about oral option. Please do a dysphagia screen. Do a dysphagia screen in the patient for you to be sure that the patient can swallow.
Thank you for repeating
that. If you are not sure, please revert to IV medication. Thank you. Over, Jess.
I'm putting that in the chat as well. A critical point to ensure the patient can swallow before you give them anything by mouth. A dysphagia screen is critical. You certainly don't want them to aspirate.
Perfect.
Thank you.
Perfect.
And a few months ago, actually, some of you were here, we covered alternative routes of drug administration. So remember that you can give some oral antihypertensives rectally. You should talk to your pharmacist before you do that. But if you don't have an IV for whatever reason, or the patient's not tolerating an IV, those kinds of things, you can give some oral medications rectally. So always check with a pharmacist before you do that, but just remember that is a potential option.
Yes, I think it has been a great time together with this participant. Lovely participant. Thumbs up to everyone. I appreciate you for this time out.
Thank you so much, Emmanuel. I'm going to close the Zoom video, but if you have questions for Dr. Idowu or me, feel free to email us. And thank you again, everyone, for attending today. It was wonderful having you.